shaped nucleus with little more cytoplasm, more eosinophilic cytoplasm than required. And this was basically nodular fasciitis. So nodular fasciitis, we earlier, I have already told, nodular fasciitis was earlier considered as a reactive lesion, and also because nodular fasciitis in most of these cases, they disappear in a due course of time. And that's why this has been called as transient neoplasia, but neoplasia. It is a neoplasia, though it is short-lived. So it was categorized under transient neoplasia, and it may have little bit of mitotic activity inside it. Characteristically, USP6 gene rearrangement will be there, and if you can prove that USP6 gene rearrangement with the MYH9 fusion partner, these are the differentials only. Nodular fasciitis, aneurysmal bone cyst will show you USP6 rearrangement, myositis ossificans, cellular fibroma of tendon sheath, and fibrosis pseudotumor. There are certain variants which I will try to skip because nodular fasciitis has the spectrum of proliferative fasciitis, myositis with the similar picture. In the proliferative fasciitis or myositis, you will also have the rhabdomyoblast-like cell. So again, frightened, looking at the cell, you are having a rhabdomyoblast-like cell, तो rhabdomyosarcoma क्यों ना बना दें, वो तो rapidly grow कर ही रहा था. So there are certain chances of committing these errors, looking at only one thing. Like if you are looking at the mitotic count, if you are only looking at the growth of the tumor, you should know these mimics also, or these characteristic tumors which may confuse you. Always remember the ischemic fasciitis, ischemic bowel disease, ischemic colitis. There will always be certain kind of vascular changes, hemorrhage, RBCs. So here also the same rule applies. If you are dealing with ischemic fasciitis, there will be spindle cell fascicles intervened by many RBCs and blood around. This is AIIMS Patna, the admin block where we sit and work in our laboratories. This is the panoramic view of our campus. I invite you all there very soon. Coming to the fibromas, we have different types of fibromas. Once you are dealing with fibromas, look for plenty of collagen. Talking about fibroma, if there are plenty of collagen, it's well circumscribed, call it some fibroma, but which fibroma? So for the theoretical purpose, I would show certain examples like elastofibroma. You have lot of collagen here, but you see there are beaded structures. These are basically the collagen degeneration. The disintegrated collagen is there. Once you start seeing this in a richly collagenized tumor, which is well circumscribed, probably you are dealing with elastofibroma. And you put an elastin stain, it will clearly highlight these elastin fibers or the intervening collagen. The fibrous hamartoma of infancy, as we all know, different tissue types in one area forming a mass or tumor-like lesion forms the hamartoma. Here also we have fascicles of spindle cells, the immature fibrous cells, and intervened by mature fat. Nuchal type and Gardner type fibromas, here only one point to be taken. Gardner type fibroma, जब आपको देखिए, आप इस picture को देखें, you only have collagen here. You will only have collagen. You don't even find a cell. Many a times what happens is if you are finding such collagenized lesion, you will say it is normal. There is no tumor here. This happens. But this is a tumor, and particularly if this is the tumor, you should inquire whether the patient is also having other lesions. Endoscopy में उसके पास बहुत सारा polyp हो सकता है. Basically, the Gardner associated fibroma is derived from the Gardner syndrome, जिसमें बहुत सारे APC वाला जो lesion है, familial adenomatous polyposis वाला, उसमें बहुत सारा lesions मिलेगा, including the skin lesions in the form of Gardner type fibroma and also the polyposis. There can be fibroma of tendon sheath, very bland looking cells, dilated vessels, and the calcifying aponeurotic fibroma, which I had already talked about. You see lot of calcification there in the interspersed between the fibroblastic cells. Lot of calcification, sometimes bone formation. So calcification and ossification both can be found, and if it is an abdominal area, you call it calcifying aponeurotic fibroma. We come to the case 2, which is 3.5 centimeter mass in the upper arm, elevated above the skin with discoloration. I would like my pathology friends sitting there on the back to speak out. What do you think looking at the first? Do we have a pointer here? Okay. This, oh, it doesn't give. Just above the Ki67, look at these two morphological patterns. Thank you so much. So we have the skin here, and there is a grain zone, and then there is a kind of circumscribed tumor, but not that well circumscribed. And look at the base of this tumor. This tumor had, fat infiltrating into the tumor, or basically the tumor infiltrates into the cell, into the fat. So most likely, and this history, elevated above the skin. So this tumor has a tendency to start as a plaque on the upper arm or trunk or the neck, shoulder. This will elevate above the skin. This will infiltrate into the deeper fat, and it will be kind of not well circumscribed or little infiltrative. And it is also showing us, this pattern where we can also find some storiform pattern, and this is the CD34, which was strong diffuse positive. So this was dermatofibrosarcoma protuberans. Dear PGs, everywhere you get a term called dermato, please consider that this lesion is here somewhere. 3 layer mein hi hoga. It will not be in the epidermis. So the lesion has to be confined in the dermis, or the lesion has to be confined within the subcutaneous fat, or maybe the lesion is encroaching from the dermis to the subcutaneous. All these lesions like benign fibrous histiocytoma, which is also known as dermatofibroma, dermatofibrosarcoma, all these lesions have a overlying skin. Now, if you had to differentiate between dermatofibrosarcoma and dermatofibroma, we have certain, subtle points which can be taken into account, like there will be epithelial proliferation in case of DFSP, while the dermatofibroma, while the DFSP will have a thinned out skin there. So epidermis will be thinned out in DFSP. The BFH will show, kind of a grain zone, and there will be histiocytes present in that. So DFSP का 2 ही बातें मेन है. It will be diffusely 34 positive. मैं आपको 3 cases दिखाऊंगा. I will try to skip certain slides because I know it gets heavy when you keep talking about the molecular changes and IHCs. We basically deal with morphology more than the ancillary tests. So I would also spend time on the morphology only mostly. So 34 positive tumor, skin के नीचे, poorly circumscribed, infiltrates into the subcutaneous area. You see fat in the tumor at the base, dermatofibrosarcoma protuberans. If you have the collagen A1, call A1 IHC marker, you are sure that you are dealing with a DFSP. Always remember that 34 is kind of a diagnostic requirement for DFSP diagnosis. But once the DFSP starts transforming into a malignant tumor or dermatofibrosarcoma, no more protuberance, only sarcoma, then 34 will not be there, or it will be very patchy. It starts getting lost. It will only be present on the periphery. The center doesn't show CD34. And we have encountered such cases. DFSP lag raha tha, 34 lagaya, aaya nahi. Then we started counting the, put Ki67. We already know that DFSP is an intermediate grade tumor, so it will already show, more than 5 mitotic activity, mitotic count. And Particularly when it is transforming into malignant, it will show even more mitotic index. So then we revisited, we looked at the mitosis, we also found the necrosis, and then we saw that that is the reason DFS page is transforming. That's why we are not finding 34 here. Case 3, 40-year male. It's a retroperitoneal mass. As we can see here, there is a mass on the back of probably the kidney here. And this lesion looked quite busy with, अगर मुझे बताना होता कि ये ट्यूमर को इसमें क्या क्या मिल रहा है, तो मैं कहूँगा ये वाला मिक्सॉइड एरिया है, because it is looking more clear, more edematous or whitish. We have cellular area, and then we have many interspersed lymphoplasmacytic cells. This tumor also shows eosinophils. Maybe it will also show you some giant cells. So then we are dealing with, yes, we are dealing with inflammatory myofibroblastic tumor, and this also has ALK positivity. And again, ALK आ गया, अच्छी बात है. ALK नहीं आया, it doesn't mean that you are not dealing with inflammatory myofibroblastic tumor or inflammatory pseudotumor, because it comes in 50 to 60% of the IMTs only. So ALK is not to be totally dependent upon. So coming to case 4, we see a 35-year male with deep painless enlarging mass in the thigh here, like T2 weighted image pe, it is appearing little dense, mostly circumscribed. History of hypoglycemia. The patient is having history of hypoglycemia. I'm sorry for the picture, but we can still appreciate this is the skin, this is the grangione, and this is the tumor here with some vessels. I will show some more photographs. So we are again seeing a vessel here. What do we call this? This is the same hemangiopericitomatous vessel or hemangiopericytic vessel. We are not no more calling any tumor as hemangiopericytoma unless there is only one exception. Please do not diagnose hemangiopericytoma now. There is only meninges which has still retained this tumor. If you have to diagnose hemangiopericytoma, only diagnose in meninges or the brain. It's everywhere else. It is only a pattern and probably denoting some other tumor. So what tumor it should be? Marked HPC-like vessels, storiform pattern here and there, BCL2 positive. I'm sorry for the photograph. 34 was positive. And then we have this rescuer which was positive. We have this in our lab, and this was STAT6. कौन सा ट्यूमर हो गया ये? STAT6 is for solitary fibrous tumor. So solitary fibrous tumor we have already talked about. There will be a STAT6 SNAP2 gene rearrangement, and 40 to 70 years of age is the commonest age. Problem is why I gave hypoglycemia, because these tumors have a growth factor playing the role of this tumor's growth, which is insulin-like growth factor. So once you have the patient which is under the influence of something like insulin, it also would give you hypoglycemic picture. So the tumor grows under the influence of insulin-like growth factor. If you look at some of the fish images, there will be, see, the normal will be one green, one red. I don't want to go into the detail of fish now, but see, there is a chromosome. I have labeled one part of this chromosome or one gene here. Long arm पे एक जीन था, उसको मैंने green कर दिया. Short arm पे एक जीन था, उसको मैंने red कर दिया. अगर इन दो जीन्स का फ्यूजन हुआ होगा, तो red और green fuse कर जाएंगे, and it will produce a yellow signal. So at certain points, you have to detect a yellow signal, and then you say that these targeted genes which were earlier labeled with green and red fluorochromes have turned yellow. There is a fusion, and this is diagnostic. In the solitary fibrous tumor, and then we come to adult and infant type fibrosarcoma. I have already reiterated, fibrosarcomas are to be diagnosed after exclusion of all the other sarcomas. Because they are not very common, and also if you are diagnosing something as fibrosarcoma only looking at the morphology, probably you have missed out many other morphological mimics. Infantile fibrosarcoma is very restricted to the age, so first clue will be the age. Infant age group में ही मिलेगा, दूसरा इसमें भी herringbone pattern मिलेगा, और तीसरा NTRK3 fusion मिलता है. So if you have an infantile fibrosis, I recently diagnosed one case, I think before coming here, some 4 or 5 days back, we had